G'day, legends, and welcome to the very first research review. So don't be too concerned if I'm not looking straight at you. I definitely will speak to the camera, but I've got my big, massive, huge monitor at the side of Tasmania behind my computer, which is going to have the study. So this study is really, really cool because, as with all things in healthcare and really medicine, we tend to see new treatments come on the block. I mean, DP or Dextrose Prolotherapy, I'm just going to abbreviate it to DP because I'll be saying it a lot, has been around for quite a while, but starting to see some stuff definitely in the foot and ankle space. And as with all things, they seem to try it with plantar heel pain or plantar fasciitis. And there's a couple of courses that are coming out in podiatry in Australia where you can go and learn to do that. So as a practicing registered podiatrist in Australia, I can go and qualify and basically do a course to be able to administer this. I currently don't work with anyone that's used it, or I haven't had much experience. I've had a couple of patients that have tried it in the past and they didn't get very good results. So I'm not skeptical in any sense. I just want to see a couple of more studies and maybe hear a little bit of anecdotal stuff from some people around. But let's get cracking. So title of the study, you can see there, the effect of DP versus placebo and other non-surgical treatments on pain in chronic plantar fasciitis. So systematic review and meta-analyses, which is really cool. So this should only maybe take 5 to 10 minutes. We're going to whiz through it. A couple of things highlighted that I'm going to talk about, but everyone knows plantar fasciitis, what is the cause, is not the goal of this video. But as you can see there, around 10% of people in a lifetime are going to have plantar heel pain or plantar fasciitis, and that ranges from like 9 to 10%. Interesting, they put this right at the start. Although anti-inflammatories are considered the first-line medical option for the treatment of plantar fasciitis, I guess they said medical, but definitely not. Like, anti-inflammatories are not first-line therapy for plantar fasciitis at all. There was a really good systematic review done by Ian Griffiths and a bunch of guys, and it was published in BJSM, free access, and they talk about like the core treatments, things to consider if they're failing, and then kind of going further down the line of evidence, and things like education, high forefoot to rear foot drop, shoes, that kind of thing, and plantar fascia stretching as well, and low dye taping were more considered first-line therapy, not anti-inflammatories. But anyway, so getting into a little bit more of the information, I'm just going to move myself, which is freaking awesome that I can do this. That's cool. So they also go on to mention that cortisone and PRP injections, exercise authorities, prolotherapy, and shockwave are other treatment options for plantar fasciitis, which, yeah, they definitely are. I mean, talking about non-surgical stuff, they didn't really touch too much on like an exercise, plantar fascia stretching and calf raises and those kind of things. But what's interesting is when you go back and look at that recent systematic review that I was talking about before, they talk about injectables and things like that and shockwave, but it's nowhere near what people probably think. So there's roughly 4 levels that they talk about, like first line, second, third, and fourth, and shockwave and injections are down in the third and fourth. So they're not recommended at first line at all, and they probably could have went in and said a little bit more about that. But anyway, so a little touch on prolotherapy. Injection of a small volume of sclerosing or irritant solution into an uninjured tissue. That's basically it. How it works, similar to shockwave, we just don't really know. And when I'm speaking with patients, I'll be really transparent and say, this is how we think it works. I've definitely seen good clinical results. The harm is very low. And of course, if things aren't progressing or things aren't improving, we don't have to continue down that route. So they put there, it is known to promote tissue regeneration and repair, release substance P. I feel like that's a bit of a hot word. They talk about that in shockwave as well, and induce fibroblast activity and vascular growth. Man, vascular growth sounds cool. If I was a patient hearing that, I'd be like, that sounds good. But they talked about as well in the intro, they said a very recent systematic review and meta-analysis evaluated the effectiveness of DP in plantar fasciitis and reported potential long-term benefits of DP. I'm not going to talk about that systematic review, but as with all research papers and studies, that one had some inherent issues as well, but still something to lean on. So I'm not going to touch too much on the methods and a lot of the criteria, because the goal of these these reviews is to keep it somewhat short, but also for you guys to stay engaged. And I know that if you're reading this and I'm talking about the Cochrane collaborating tool for risk of bias and assessing risk of bias, you're going to drown out and not get the whole point of the study. So I'll quickly touch on this. They use the Cochrane's collaboration tool for assessing risk of bias instead of the Pedro's risk. The reason for that, they say, is it does not meet the accepted quality standards such as a generation of random sequence, which is really important, concealment of allocation, and blinding of study assessors. So we're not going to talk too much about research and what makes really good research. That's for another lovely video, but these things are important. And as you'll see with this study, there was a high risk of bias in 7 of the 8 studies they included. But let's get to the selection criteria. So male and female, aged over 18. They said that they excluded people with a history of trauma to the foot, especially to the heel. And yeah, I don't know what they meant by that, but I'm assuming, something like, maybe a sprained ankle or a fracture, and there was some heel involvement, I'm assuming. But the primary outcomes, 2 really important ones for us as podiatrists, and I guess any health professional really, pain is really important because that's why people generally come in to see us, and foot function. And they use a couple of different metrics there. But the follow-up time after each final session of the treatment, which we're going to talk about, when they evaluated, they basically had foot function and pain and then measured each in the short, intermediate and long term to see if there was improvement. So the follow-up times were intermediate, less than 1 month, short term 1 to 3, intermediate 3 to 6, and long term over 6 months. So study design is there, eligibility criteria, search strategy. The cool thing is this study is open access as well, which is really cool. So talking about the risk of bias, the following parameters were evaluated. Random sequence generation, that's important, so people get allocated randomly to a group that might see or might get the placebo, which may be saline in this case. Allocation concealment, that's important. Performance bias, that's important. Detection bias, attrition bias. So one thing here which is pretty interesting, especially in these studies, and when you're doing, I guess it's hard as a practitioner, inherently you're always going to have, I'll just move that over, realize I didn't move that. So you're always going to have people not come back. That's just the reality of healthcare. I don't think there is any health practitioner on this earth who has seen their patient from start to finish all the way through. They will be in patients that don't gel with, or they don't respond well to the treatment, and you perhaps didn't give enough information to say, hey, you need to come back and see me if this isn't comfortable or something's not going right. And they go, whatever, that guy didn't give me the right information, I'm going somewhere else. Attrition bias is basically when people not come back to see you in a study version, and then when you go to look at the outcomes at the end, you don't count those people. So let's say I shockwave 10 people and 5 go really well and takes all their pain away. And then for 5 people, it goes really bad and they don't do very well and they drop out of the study and they don't come back. If those 5 stay in the study that did really well, at the end, I can say, great, we had 100% success rate. Everyone had no pain. So it's when people can drop out, which is, I would say, almost more common, when we're thinking about giving people injections, if there's any irritability or the outcomes and what they expected to happen doesn't match what we tell or explain can happen, but that's a really important one. So going through to the next couple of pages, looking down at the results. So DP was compared with shockwave in 3 of the studies. Plate or PRP was compared in 2 studies, and only 1 study administered DP along with exercise, in which the control group received saline injections plus exercise. So that's a pretty cool study. So we can somewhat, I guess, assume that patients thought they were getting it when it was just saline. So you can get a bit of an idea, if you give one person saline and one person DP for the same condition, and there is a difference, where you can kind of hope to assume that it's because of the DP. So, and DP was compared with cortisone injection in 2 studies. 449 people, average age 36 to 57, which is pretty good. Like, that's probably how I would see plantar heel pain, pretty distributed. And sample sizing ranging from 20 to 158. average pain from 8 weeks to 2.9 years. Now, one thing that's really interesting, the concentration of DP ranged from 1.5 to 20%. Now, that's a fair bit. So you imagine 1.5% versus 20, that really significantly changes the outcome. So if I give someone 1.5 and they don't respond, it could be in many reasons, but it also could be I didn't give enough. So knowing that, and then when we draw conclusions, if we say, DP wasn't effective, was it really that it wasn't effective, or was it the fact that we just didn't use enough in that solution? But anyway, and the next part of that was the frequency of DP ranged from 1 to 3 injections, 1 to 3 weeks apart. So that's also important. And we know, similar with PRP, having the injections close together, some research says you've got to have 2 to 3, a certain amount of weeks apart. If you have just one off, it may not be as effective. So, maybe the case with DP. I would definitely say we have more research looking at PRP and its frequency and the results compared to the DP. Now, looking at the immediate term effects on pain. So, all the included trials reported short-term effects on pain, while only 6 reported immediate term and 3 long-term effects on pain. So, pretty cool. One of the studies, which from Ursum and Mazines Kaplan, showed significant immediate term pain reduction with DPT compared to exercise and placebo. So, that's hard. I mean, you would hope that it does better than placebo, which is nothing. But when you think of plantar fasciitis, and it's hard because there's lots of different versions, I guess, of plantar fasciitis. So someone can have plantar fasciitis and tensile forces be aggravating, and someone can have plantar fasciitis and more compressive forces can be irritating, or it can be a combination of both. So I would say that in the more compressive type, I really don't prescribe much exercise, at least initially, for those people, because it's not really the goal of our treatment. It's trying to unload them and give them things that are going to help with their pain. So that was interesting to see that DP beat that, I guess, or compared and did better, but probably not as surprising. And you think, what I was thinking with this was, in the immediate term, when someone's really irritable with plantar heel pain, or they haven't seen you at all, just seeing someone can sometimes make you feel better, in the fact of someone just comes in for initial, you tell them what's going on, what's the likely prognosis, what we can do about it. If you did nothing else, I would almost assume that, I would think and like to hope that people would probably feel better anyway, at least having a plan and understanding as to what's going on. But in the immediate term effects on pain, they concluded that overall, DP was not superior to placebo or other non-surgical interventions for immediate term pain reduction in plantar fasciitis, which was interesting. And when you read that, you're like, maybe it's not that great, but I was saying it wasn't superior. So it doesn't mean it's just as good, it just wasn't superior. So it's similar to say that surgery is not superior to of the ACL is not superior to non-surgical management. So knowing that it's not superior doesn't mean that it's worse and it's horrible. It just means that it wasn't better. So having a look at the short-term effects on pain, Yume, Atlas, and al. showed that DP was significantly more effective than placebo, which we would hope, for pain reduction in the short term. And Kaplan and al. also reported that a significant short-term pain reduction with DP compared to placebo. So again, you would hope that these things do better than placebo. But interesting seeing that short term and immediate term. I mean, they're probably what patients care about the most. They wanted their pain to be fixed as not as quickly as possible, but you get more buy-in and patients are happier when you can help their pain initially in the short term. Moving on, though, when we look at the long term, we can see only 3 trials evaluated, and overall, the effect of DP compared to the control groups was non-significant. Again, it doesn't always mean that it's the worst. It doesn't mean that it's the worst and we shouldn't do it, but just saying it wasn't significant. So, having a look now at foot function, so that's what we saw with pain. I thought it was interesting with some of the characteristics. So these are the included studies that they use. Looking at this one here, the DP group versus the control group. The control group got plantar fascia and Achilles tendon stretching exercises 3 times a week for 3 months, plus same exercise protocol of their own 3 times a day for other days. So interesting, I mean, if it's more the tensile, I'm not giving them stretching, I'm giving them resistance training. You know that study in 2014 from the Ralph protocol where, you have the towel underneath the big toe. So I would like to see that more with strengthening, but that's okay. And then in this one, straight below, the shockwave. So again, when we look at shockwave, I know they classify it into different versions. So, whether it be focused or more generalized, looking at that level, that's variable as well as to what some people would do. So knowing that, it might come back that, it wasn't superior. It wasn't superior to shockwave, but then if we do the shockwave protocol that other people may do, somewhat like myself, it may end up being not superior or more superior. So it's always hard. And that's why it's awesome when they do, great to see when they do 8 studies or somewhat less, because you can have a look at these and really go through them. When there's like 20 or 30, it's a lot more to go through and a lot more work, but it's cool with these studies. So looking at foot function, overall, they concluded DP was not superior to placebo or other non-surgical interventions for immediate term foot function improvement in plantar fasciitis. For short term, there were significantly large short-term effects, which is awesome, great for foot function. They go on to say, and Atlas et al. In one of the studies showed that DP was significantly more effective than placebo for foot function, again, which you would hope. And looking down there as well, DPT was only significantly superior to exercise and placebo for short-term foot function improvement, while it was not better than PRP, cortisone, or shockwave, which, was interesting. You can see up through here, which I've highlighted, looking at all the studies, the category or the risk of bias, high, unclear, high, high, high. So take that as you will. And moving on to the immediate term effects on plantar fascia thickness. Again, I didn't really go through this myself that thoroughly, or am I going to go through it in this video? Because and this is just my bias, I don't think it's that important because I don't really see that thickness and pain correlate that well. But anyway, similar with tendons. So in the discussion, overall, DP was superior in terms of pain reduction, foot function improvement, and decreasing plantar fascia thickness in the short term. So not the immediate, but the short term, which was 1 to 3 months, which is great. Again, as we were talking about, plenty of issues, performance bias, attrition bias, people not getting blinded, knowing that you're not getting the intervention. Like, it's pretty hard if you're a patient and you get told, what group you're in, or you're getting told you're getting an intervention and they don't inject you, they just give you nothing, or they give you some exercises, you probably have a little bit of maybe a suspicion, so that could affect the results. But anyway, what they think, and they talk about this a little bit here, and I just thought that was interesting. So when people ask, the process they think seems to be activated as a result of localized trauma caused by the injection of hypertonic dextrose, leading to soft tissue healing. They go on to talk about some of the other times where Prolo has been effective, but some issues with that where it's more generalized and it just works for anything because we're not looking at a specific condition like we are in this study with plantar fasciitis. So one of the limitations, very few number of studies included, and there were insufficient trials in most of the subgroups to achieve conclusive results. So take that as you will. But in summary, DP was only significantly superior to exercise and placebo for short-term pain reduction, while it was not better than PRP, corticosteroids, or shockwave. So, pretty much what I already thought. I thought that it would be effective, definitely, but as with anything, it's not going to be the magic wand or the silver bullet, and I didn't think it would probably do much better or better than shockwave and PRP and cortisone. Still, going back to that study that I mentioned at the start with Ian Griffiths and the people that he worked on it with in the BJSM journal, knowing that there's definitely other things that we can do, like taping and stretching and footwear and orthotics before looking at this. Could you do it in combination? Of course. One of the interesting things with this study is they report that there were no adverse reactions. Sorry, with this review, none of the studies within there reported any adverse reactions. I thought that was interesting. I assumed that there would be because I've read some studies where they do dry needling and they report some adverse reactions, but not in this case, which was good. So hope you enjoyed. Guys, please reach out. Remember, follow us over on the Instagram or listen to our podcast, which is the Sports Medicine Project. Give us some feedback for this course, how you like these reviews, and we'll see you guys next week.